very good morning, good afternoon, and a good evening to everybody. Swadikap to all of my colleagues in Thailand. As we recall, Thailand has been one of the leading countries in WHO's Southeast Asia region to respond to viral hepatitis C. In 2012, we included pegylated interferon as a part of our national essential medicine list. And then from that time onwards, our program has slowly been evolving. Of course, we have had our own progresses and we have also had our own limitations. It was further developed with the inclusion of direct-acting antivirals, some of direct-acting antivirals, I would say, in our list of essential medicines in 2018. With contributions from different civil society organizations, researchers, physicians, government institutions, we continue to progress in our work. And of course, some of the challenges remain, and that's what we're trying to talk about today and sort out a few of the things that we could, and further narrow it down to other discussions as we move on further beyond this webinar. My name is Giten Khairakam. I work with Treat Asia Amphar in Bangkok. And on behalf of our co-organizers, Drugs for Neglected Diseases Initiative, the NDI in short, Faculty of Medicine, Siriraj Hospital, Mahidol University, Siriraj Institute for Clinical Research, CICRIS in short, the Thai Association for the Study of Liver, and my own organization, Treat Asia Amphar, I would like to welcome you all to this very important conversation today. We have a list of distinguished speakers who are not only well known in Thailand, but also globally in the response and have contributed immensely as physicians, researchers, government officials, civil society representatives in our endeavor to improve access to diagnosis and treatment for hepatitis C. At the end of our conversation today, we would like to have some key points which we could take down as action points and could discuss in Thailand, further narrow, possibly through physical face-to-face meeting if the situation allows. That would allow all of us to take our country towards elimination of viral hepatitis by 2030, in this case, specifically hepatitis C. So we would appreciate your thoughts, ideas, contributions to enable have a very fruitful discussion today. Dr. Anjali, who was supposed to speak, had some personal issues, a bereavement in her family. So she unfortunately would not be able to join us. So in place of her, we are very thankful to Dr. Nithya Phanupak from IHRI here in Bangkok, who would speak on possibilities of same-day test and treat for hepatitis C among key populations in Thailand. And you must have seen a mail that has gone out on this from the organizers an hour back. A bit of housekeeping. We do not have a Q&A box, so please feel free to share your questions to the panel in the chat box. Our colleagues are monitoring it, and then we'll forward it either to me as the moderator of the initial sessions or to my colleague Jean-Michel in the later part of the session. If your question is to a particular speaker, please mention the name of the speaker before the question so that we can direct it to the appropriate panelist. The session is being recorded for the purpose of our own minuting and ensuring that none of the action points that has been shared are dropped out from the discussions and further follow-up. We will take questions at the end, which is cited in the agenda as open discussion forum. That is where we are in terms of how our proceedings would go. To start the first talk of the day, I would like to invite Associate Professor Thawisak Tanwandi. Many of us know him here and also in abroad. He is currently the head of Division of Gastroenterology, Department of Medicine in Siriraj Hospital here in Bangkok. He was also the president of our Thai Association for the Study of Liver in between 2015 and 2016, as well as the president of the 4th ASEAN Perspective in Liver Diseases in 2016. He is also secretary of the Liver Foundation of Thailand. Professor Tanwandi, over to you about overview situation of hepatitis C in Thailand and considerations.
Thank you, Credence, for your nice introductions. For interest of time, I just to bring you to the situations of Hep C in Thailand and engagement of the professional societies. So the outline got to cover on the risk and burden of Hep C nowadays and evolution of Hep C treatment reimbursement. So it's got to be reimbursement that would be the main issue for us in Thailand and challenges for the treatment. We are aware that especially in Thailand, most of the most important risk factors going to be exposure to blood products before discovery of Hep C. That was before 1990, where we did not have any screening for hepatitis C, and among another important risk factor going to be PRIT. This is going to be the very high risk factor for getting hepatitis C. Those in blood donors with history of PRIT more than 6 months, 95% going to be positive for hepatitis C, and some of those who used unsafe injection, for example, for those days there was a reuse of syringes and needles. That got to be the cause of infection. With the introductions of NAT screening in blood donor, as well as reductions of PRIT community in Thailand, so the burden of Hep C has reduced dramatically within the past decade. So nowadays, this was the study done in 2014. It was estimated that there were about 260,000 cases of hepatitis C burden in the country. This got to be roughly, I think, in the range of 100,000 in the country. We don't know exactly because most of the study are limited, but this is maybe the study that can represent general population. And until the goal for WHO for hepatitis eradication back in 2016. So again, with DDC, Thailand has announced the strategic plan for hepatitis eradication. Dr. Montani is going to cover on this. However, in terms of professional society engagement in addressing the Hep C problems, we have such a concern in the Hep C problems in Thailand even before establishment of Thai Association for the Study of the Liver. However, those days the treatment was conventional interferon and ribavirin, and until in about 20 years ago, it was switched to PEG-RIBA. And we have worked closely with DDC and the HITAP in order to push forward for treatment reimbursement for hepatitis C, as well as to propose Hep C screening. And this is the representations of the guideline developed over the time, or when the new drugs was available. So we changed the guideline periodically in terms of the treatment of chronic hepatitis C. However, the problem for Thailand is the diversity of Hep C genotypes. About 50% genotype 3, and the rest 50% either genotype 1 or 6. So this is the problem when the first reimbursement was done, because for genotype 3, the treatment was 6 months, and genotype 1 with PEG-RIBA was 1 year. However, even with the original price of PEG, so we have shown that the treatment is not just cost effective, but also cost saving. So that was the reason why PEG and RIBA had been proposed for reimbursement as for 2012 for the treatment of chronic hepatitis C. Until the availability of generic oral drugs for Hep C, but again, since we have genotype 3, and that time we don't have generic daclofenavir or any drug for covering genotype 3. So for genotype 3, the soft pegribar was replaced by pegribar, and for non-3, soft lead was the main reimbursement drug. And this changed to software just beginning of this year. So now the treatment going to be software for all genotypes, so we don't do genotype anymore. However, for those with cirrhosis, that's going to be child B and C, ribavirin is automatically added to the software. So the challenge remains, according to the reimbursement guidelines, we need HCV RNA greater than 5,000 IU per ml. We need fibrosis of at least F2 or more, and the treatment requires specialists. So, and moreover, we don't have screening program, so we need to treat the patient while they know that they got Hep C, and the public awareness is low. So what we are looking forward is the point of care test for active Hep C finding and treatment. So it's going to be test and treat phenomenon, and this is going to be done in any hospital levels. By the way, during this time, we have cooperated with DDC in order to develop more simple guidelines for the treatment of Hep C. So this is going to be the way that we can move forward for the treatment of Hep C by using not only specialists, but any doctors can treat Hep C. So with the contribution and collaboration with all parties, the treatment can be achieved, and hopefully we can achieve the goal 2030 of WHO. In conclusion, Hep C is one of the major health problems in Thailand. Road to elimination of Hep C in Thailand is challenging. Collaborations of all parties required in order to increase the awareness and of Hep C problem in community and healthcare personnel. Healthcare innovations for Hep C elimination is considered, especially we need to consider this problem as a healthcare problem, not a specialist issue. We need to get rid of all barriers to the treatment. So in order to do so, we need a simple guideline, and anyone can follow with locally available tools. Registry may be another thing that can avoid duplicate tests and treatment, and also this can allow us to follow the patient after the treatment. Thank you.
Thank you very much. Thank you very much, Dr. Thavisak. I think it's very clear your talk covered a wide range of progress, at the same time limitations that as a Thai public health program we have been talking about and facing. One of the key things is around inconsistency in terms of estimates. And we see a varied range, as you have pointed out, and some of the highest that I have seen is 400,000 chronic hepatitis C. And you also pointed out other figures that has come out of our country as estimates. Another challenge for us is a high, for a long period of time, is a high concentration of genotype 3. And even when the AAs came out, we had to expose patients to PEG interferon because we simply did not have that option. And hopefully that would change because we have started introduction of soft velpatasvir as pan-genotypic regimen beginning of this year. I also completely note the fact that we have challenges. A lot of countries have simplified, if not hepatitis B, at least hepatitis C testing and treatment has been simplified to a large extent, including our own neighboring country, Myanmar. And in many other places where national programs have been undertaken. We have limitations in terms of choice of drugs. We have limitations in terms of fibrosis staging of F2 and above. These were consistent when we were using probably PEG interferon era, but perhaps that is something that we could reconsider when we have pan-genotypic regimens at this point. A simplification of guidelines so that primary healthcare providers are enabled and trained to provide rather than relying entirely on specialist care. At the same time, I note that you talked about improving awareness among people because it's a very slow disease. And when patients present themselves, they present very late. And when they have cirrhosis or even decompensated cirrhosis, that's when they actually come to receive care. So thank you so much for your talk. We will pull up more as and when we go on to the discussion session. And I'm sure some of this talks again would be pointed out in our other panel. Next, may I please invite Dr. Montini Vasanti Papakorn, who is now currently the Deputy Director of Division of AIDS and STIs, Department of Disease Control in Thailand. She started her professional career with Ministry of Public Health in 2012 as a medical officer of HIV Prevention Unit, and then went on to the Chief of Prevention Technology Promotion and Development Cluster during 2013 to 2017. She was also one of the PI in the trial with sofosbuvir revidasvir in Thailand, which we would hear about, and later in the program, it would also was also a co-PI in microelimination work in Thailand and Phetchabun. Thank you so much, Dr. Montini. Your 10 minutes starts, please.
Okay, can you see my presentation?
Yes, we can see your presentation very nicely. If you could do it in a slideshow, that would be very helpful.
This internet is slow. I'm sorry. Just a minute. Okay, you can see the full screen.
Perfect. Thank you.
Okay. Today good afternoon, everyone. And today I present that the Thailand National HCV program and program status and progress and challenge. And the next slide. This slide show you that the strategy of eliminate hepatitis 2022 to 2030, that we collaborate with network for set the strategy, and now is not yet. And it is like a hearing. Okay, and the vision is Thailand is free from hepatitis that pose threat to people's health and life, and goal is eliminate hepatitis B and C, which are a major threat to people's life and life by 2030. Target, we have two targets that followed by the WHO. I think first is reduce the incidence of hepatitis B and C virus by 90%. And second is reduce mortality rate with hepatitis B and C by 65%. We have 5 strategies. It is a new for not yet. Its first is accelerated the provision of service to prevent new hepatitis infection. And second is promote access, coverage, and quality of care for hepatitis B and C. And third is reduce disparity and health inequality related to hepatitis. Fourth is develop surveillance system, information system, research, innovation about hepatitis. And fifth is develop structure and mechanism with integrated share responsibility and effective management. The target is an strategy. First target is incidence of hepatitis B and C in Thailand has decreased by 90%. And the target of second strategy is reduce hepatitis B and C infection, access to comprehensive quality care not less than 90% and reduce death from hepatitis by 65%. And strategy, third strategy is the target we set. The least people have equal access to screening and care without bias in demographic, race, religion, and occupation and local context by 90%. Fourth target is at least one surveillance system, information system, as well as research and innovation to support hepatitis elimination. And the fifth strategy we earmark that integrated, and the target is at least one system of an integrated structure and mechanism for eliminating hepatitis B and C with accountability and effective measure. We emphasize for leverage, access, coverage, equity, consistency, quality, and we integrated that accountability like a partnership and community based. And difference between that the old strategy and new strategy in 2020 to 2030, we earmark that the third strategy to reduce health inequality and inequality related to hepatitis, and the fifth strategy to infrastructure for develop and integrated structure and mechanism create share responsibility and effective management. This slide shows you that the progress in the elimination of hepatitis B and C. We classify for the four category or four part sector. It is about the guideline and strategy and database and network. In the progress of guideline, we developing a guideline for the treatment of hepatitis B and C Thailand, and we encourage for hepatitis drug account adjustment. And the part of strategy we provide the strategy to eliminate hepatitis 2022 to 2030 that I told you in the previous slide, and encourage for the increase of benefit for vulnerable population. At the part of network, we encourage for operation together with local government organization, and we support antiretroviral drug. This is about the hepatitis B to xenophobia in the pregnant women, like a hospital participating in the pilot project of DDC. And we support the test kit in campaign activity World Hepatitis Day is about both hepatitis B and C together. And the database we set the hepatitis B and C screening result recording program, and we put the data entry program according to the project to eliminate hepatitis B virus from mother to child. And we develop a data link system from the medical and public health data warehouse system. That we show you that the benefit treatment of hepatitis B C virus, and now NHSO approved among two key POP, that is the PLHCV and PWID, is people who injected the user, and we in the process of researching the value of economic, that is for among four key population. One is a prisoner, and two is a male sex worker, and gay man, and other men who have sex with men, and 4 is a waste set sorting start. This is show you to the predicting type of hepatitis C drug in Thailand that Dr. Theresa told you in the previous part. I brief short this. In 2019, we launched the PEG interferon plus ribavirin for the pan-genotypic hepatitis C treatment, and 2019 to 2028, we launched it soft and plus and cut PEG interferon plus ribavirin for genotype 3, and in the non-genotype 3, we provide the sofosbuvir ledipasvir, and now we set the sofosbuvir and veltasvir for the pan-genotypic duct. This skip to this conceptual framework for the management of hepatitis B and C Thailand, that we have the system of surveillance and system for me to division S of S and STI for the viral hepatitis B and C screening and the reimbursement program EMPCT. Yes, and the NSSO that Dr. Phon can tell you that the mechanism for the NSSO. This slide show you inclusion mechanism for health benefit package in Thailand, that we can see if we will launch the new drug for the national essential drug list. We have to pass many working group of FDA and many subcommittee of NSSO that can you see, and this is a gap for the program of HCV. This is operational gap that about the active case finding is still minimal and limited, and the vaccine of primary prevention of hepatitis C infection, screening, care, and treatment are not yet covered by universal health corporate benefit package, and the diagnostic and care system have limitations that do not facilitate access in equality, coverage, and continuity of service, and we have lack of strategic information about the epidemic and response to plan improve effective operation, and the old strategy is unclear in integrating with related disease and lack of action plan that drive concrete strategy. This slide show you that opportunity and sharing. That opportunity to the HCV program is equity and better access to treatment, efficient health financing, and challenge is the HCV program. I think is a multi-sectoral part and time consuming and lack of expertise in health economy. Okay, thank you very much.
Thank you very much, Dr. Montini. That was a very interesting talk. And I think the national strategy moving slowly onto now a more diversified strategy from 2020 to 2030 is indeed encouraging for all of us to hear. I think this would come again later in some of the talks or in the discussions about the reimbursement criteria from NHSO. That we have already included PWID and PLHIV as a part of the reimbursement process. Could that be expanded further to cover other populations, including general population or other high-risk groups? That would be something I think that will come in the process of the discussions. The country has a process at this point to include new drugs into our essential medicines list, and that's a lot of subcommittees or working groups that brings it to finally agreeing. And thank you for sharing that information, and that slide is also very useful. We also have in the midst of us our colleagues from WHO, both from Thailand office and also from the Southeast Asia regional office. So they would have a talk later. So you pointing out from now some of the operational gaps, including strategic information and investment related matters, are really going to be useful for them to think through as they prepare and follow on from what you have presented. So thank you very much, Dr. Montini, again. Our next talk is going to be from Associate Professor Dr. Sathawat Thongsavat. And Dr. Thongsavat was a principal investigator for the STORM-C trial, which was around using sofosbuvir and ravidasvir, as many of you know. He is a gastroenterology special lecturer at the Department of Internal Medicine at Chiang Mai University. He's also a former president of the Association for the Study of the Liver, and currently is an advisor to the association. Dr. Thongsavat, please, your intervention for the next 10 minutes around Hep C program in Thailand and your reflections on soft ravidasvir. Thank you.
Thank you, Gitan, for your introduction. And it's a great honor for me to talk here. I may not use as much as 10 minutes. Well, as Dr. Tuvisak and Dr. Montini has shown many aspects of the big picture and the future of hepatitis C elimination for Thailand, I would like to raise something that might be related to, well, the trial, the STORM-C1 trial that I represent Thailand. For this trial, I think that is a good trial. It shows that the combination of sofosbuvir and ravidasvir is not bad. In fact, it might be as good as the sofosbuvir velpatasvir combination. Until now, I cannot understand. We have the representative from NHSO here. I cannot understand why we don't have the generic other anti-hepatitis C in Thailand, just like in Malaysia. I've learned that in Malaysia, they use all kinds of generic DAAs. So they have all kinds of combination that they can think of at the quite low price. If I'm not correct, please correct me. But anyway, for the STORM-C1, the use of soft ravidasvir, if we finish a study and we can get the combination manufactured in large amount and can be imported into the country, get approval from Thai FDA, and at the lower, much lower price than even the generic Softwell here right now, I think that's going to be a good choice for Thailand on the road of elimination of hepatitis C. And as I said, if NHSO consider the use of other generic DAAs as well, then we can have more and more choices for the elimination. I think that I will not touch the process of screening or access, as that's Dr. Montini has talked quite well covered. But the next step in the condition that right now COVID-19, well, is the immediate emergency, and all kinds of resources, all kinds of fundings poured into COVID-19. I think that if the policymaker can do for hepatitis C is that we should go on maybe slowly, but step by step to the vulnerable people, like the incarcerated, or more focused into the HIV co-infection. And then we gain more data, more knowledge, and more practice to gain the access to the treatment. So I think that my point of view is that of these two aspects. Dr. Visit, you can use the rest of my time. Please go on.
Thank you so much, Dr. Thangsawan. I think all of us would agree, everybody, both the global audience who are in our webinar and also from Thailand. I think all of us would agree that the more the choice of drugs are, the more the suppliers are, the merrier it is always for the national program or for our national drug procuring agency. So that is very clearly highlighted by your intervention. Thank you also for pointing out about COVID-19. I think for us who work in viral hepatitis, both B and C, and also on HIV, one of the critical thing and a very positive thing COVID would have done for us is a strengthened infrastructure for PCR confirmations. It could be molecular platforms, it could be cartridge-based technologies, and a lot of countries have procured, and I'm sure Thailand have done it too, to diagnose COVID-19. Post-COVID, this has to be used somewhere. We cannot keep all this PCR technology platforms unutilized. So that would be one thing where we can really ramp up and show how we could actually utilize this across provinces, which these technologies are mostly what we consider, or some at least as point of care at this point, are hard to access at this point. But post-COVID, we are going to get that. So thank you also for pointing out around COVID, and then we would post-COVID and we would be having all of this infrastructure. So we would also have to plan out at some point, how are we going to engage our Ministry of Public Health and Department of Disease Control colleagues to utilize those for viral hepatitis response, both B and C. So thank you so much for that. Our next speaker is going to be Dr. Pisit Tangkivanich, who is very well known, not only in Thailand, but elsewhere too, is currently the president of the Thai Association for the Study of Liver, and is also the head of the Department of Biochemistry, Faculty of Medicine at Chulalongkorn University. In 2013, he was awarded a National Outstanding Researcher Award in the field of medical science. And in 2019, he received the TRF Senior Research Scholar from Her Royal Highness, Princess Mahachakri Siriraj. Dr. Pisit, your intervention, please, on comments on the Thailand program and some of your thoughts around way forward to address the challenges and scaling up decentralization or simplification. Thank you. Over to you.
Okay. Thank you very much for the kind introduction. I think I have more than 10 minutes, but I will use only 10 minutes for my talk. Okay, it's an honor for me to be invited to join the meeting. I think it's very important for finding the way towards the HCV elimination in Thailand. I will share my slide. So can you see my slide?
Yes, we can see it. Yeah, thank you.
Okay. I think the development of BAA therapy for chronic hepatitis C infection is one of the greatest advances in clinical medicine. But I think natural screening and treatment programs are not that simple, as it requires several factors to translate the potential therapy into population level benefits. For the next 10 minutes, I will give my general comments on the current HCV program in Thailand. And I think that some of my comments are quite similar to Professor Siriraj, as mentioned before. And I will discuss a little bit about the way forward for scaling up the treatment and prevention in Thailand. Okay, since January 2021, software has been approved on the national list of essential medicine or NLEM in Thailand. As previously mentioned by Professor Siriraj, this pan-genotypic combination has a very highly effective, as shown in this slide. For example, the data of phase 3 study of software for 12 weeks is very effective in Asian population, including Thai people, as it has an overall kill rate of SVR of 97%. However, this regimen might have a slight limitation because it has lower efficacy in HCV genotype 3B infected patients, particularly for those who have cirrhosis. This slide shows the current HCV program in Thailand. The standard HCV diagnostic test in our country consists of, I think that the same as other countries, initial screening by rapid point-of-care testing or lab-based testing assay and confirm HCV RNA testing of those positive, and subsequently linkage to DAA treatment. As software, as a pan-genotypic DAA, HCV genotype testing is not necessary at the current program. However, the reimbursement process still requires the measurement of viral load of at least 5,000 IU per mil, and also assess the severity of liver disease by any means such as FibroScan or fibrosis score, FIB4, API score with a formula using as mentioned in the slide. And we treat only for those who have F2 or 3 or 4. So F1 and F0 are not eligible for the treatment. And the medication is software for 12 weeks, and also for those cirrhosis, child B and C, adding web-based lipavirin, and the assessment of SVR after treatment of 12 weeks, SVR 12 after stopping therapy. Okay, I think the current HCV program is considered to be less complicated and more effective than the previous one, as mentioned by Professor Siriraj, based on PEG-related interferon therapy. Also, I think the budget impact is decreasing significantly because HCV genotype and FibroScan are not required in most cases. However, despite these positive impacts, there are still some limitation or barrier for the current program that need to be mentioned. This one is one of the barrier. I think also software is in the list of NELM. This is currently on the E2 program. E2 program including medicines that are high cost but are important for particular group of patients or high cost specialty medicines. Before the reimbursement, we require a registration and also pre-authorization form in HSO and approved for use of medication. As already know, software has been allowed voluntary licensing in Thailand since 2017. So that will reduce the price of the treatment. However, I think it is not quite right to put the software into this category, E2 category, because this is an expensive category comparing with other cancer medicine or some new drugs. So I think it should be shifted to maybe some other category. Another barrier is the hospital where to treat HCV should have a specialist such as a GI medicine who can provide medical advice for healthcare professionals. So I think from this point of view, the general practitioners or GP are not allowed to treat the patients without under supervision of certified GI specialists. This could be a major barrier for the access to the treatment in remote areas. such as in primary healthcare center or district hospitals, where GI doctors are not available. So to overcome this barrier, TASO has initiated a remote consultation process using a nationwide hepatitis registry of patients undergoing antiviral therapy with DA regimens. This web app program is designed to be used fairly and back up the data on the cloud and have real-time web-based assessment and also have a good security program. I think that the use of telemedicine can improve the efficacy of therapy and the potential to increase the uptake of HCV treatment in these 10 areas. And also the HCV registry system will help to establish nationwide database for research network or big data for the future healthcare system. This is another barrier I will be mentioned. In the NLEM, it is recommended to use HCV under testing at least 5,000 IU per mil as a cutoff for the reimbursement. However, I think the data from systematic review show that 95% of patients with chronic hepatitis infection have a viral load more than 10,000 IU per mil. And so the most HCV assay, either qualitative or quantitative, could detect the majority of viremic infections. So I think if we use the qualitative test, should overcome some barrier as the qualitative test is less expensive than the quantitative test. In addition, I think the HCV core antigen, as mentioned by Dr. Montini, is another attractive option and could be used as an alternative test for HCV RNA in detecting active infection and monitoring treatment response. I think that for this issue, TASO has addressed this concern about using the quantitative test of more than 5,000 IU per mil to the NLEM committee a few months ago, but I think that right now we have not received any response yet. Okay. So the next barrier is the program allowed to treat only patients who have significant fibrosis or at least F2. I think that this is also critical because our previous analysis in Thailand at a resource limited setting suggests that focusing HCV treatment on patients with severe fibrosis or F4, F3 at least could have a highest number of lives per year saved. But however, following access to drugs at the generic cost and for the price later, I think the treatment with the regardless of liver fibrosis should be increasing, likely to be cost effective in the future. Thus, in the program in the future could be changed from prioritized to generalized treatment for Thai people. So my last slide and show the strategy. I think that to meet the WHO goal of eliminating HCV by 2030, a rapid scale-up of the treatment in Thailand is required. This includes the implement of national screening program to cover all high-risk groups, such as people living with HIV, people who inject drugs or IDU, prisoners or MSMN blood transfusion. I think now we only have the full coverage for HIV and also IDU patients, so we now have to expand more for other group of high-risk group. And also increase the knowledge of HCV, such as the transmission and treatment in the community is very important. Scale up of HCV testing using several effective lab tests, including point of care testing and other confirmatory tests such as qualitative HCV RNA or HCV core antigen, I think is also important. And also establish of nationwide HCV registry and teleconsultation could expand the capacity beyond GI specialists to in the hand of maybe a GP or in the primary healthcare or professional can handle and treat the HCV infection. And finally, I think the drugs should be also a very important point. Right now, we only have the software, but I think that the universal healthcare coverage program could include another maybe drugs such as the combination of levetiracetam and sulfosbuvir. I think it's very important and very effective for genotype 3. That is a major genotype in Thailand. And finally, prioritize is needed only when the supply of the medicine is limited. With sufficient supply, all patients with HCV should be treated regardless of the stage of fibrosis. Thank you for your attention.
Thank you so much, Professor Pisset. Really, that was a good capture of what is happening here and some of the limitations, and also where we have actually progressed. Keeping the suggestion of taking out these drugs from the E2 category, I think that is something which will eventually have to happen if we have more choices of the drugs, and also the realization that hepatitis C treatment could be simplified to a large extent. And WHO guideline also currently clearly indicates some of that as to how to do it, even in the form of a decision tree. Also, thanks for pointing out again and re-emphasizing some of the limitations. Clearly, the viral load and putting a cutoff of 5,000 IU/ml for treatment initiation definitely could be something that in the long term or in the short term needs to be considered. Again, F2, it's now a treat all for everybody, whoever has a RNA confirmation. So we don't really have to wait until F2 for patients to progress and then provide treatment. And also talking about rapid diagnosis that is needed if we are to move forward. And a lot of the talks, as you specified, on certain high-risk groups would be followed with Dr. Nicholas, Dr. Nitaya, and others who would be speaking in this, and also from Jockey, who would be talking about how civil society have contributed in that process of reaching out to high-risk groups. Thank you for also last pointing out the choice of drugs. I think given the situation that we have now globally in terms of drugs availability and regulatory uptake, we are pretty short of choice of drugs. We just have soft valprotasvir as a choice of a pangenotypic regimen. We can get definitely soft daclatasvir, which is very good for 50% of our genotype 3 of our patient population, which is genotype 3. That's also in the picture, and also what Dr. Thongsavat also has spoken about in terms of soft rabidasvir. So options are definitely there, and the more the merrier, definitely. That is how I would interpret, and that's what we have seen. Competition definitely pushes the prices down and also increases coverage through a national program. Thank you all. Thank you, Dr. Montini, Dr. Satawat, and Dr. Pistet. Thank you so much for your interventions. I think now we can move on to our open discussions. So in case if you have any questions, please do share it in the chat box. There has been a lot of things that has been happening in the chat box, so you can monitor some of the things that are there in the chat box. But this would be a 20 minutes discussion, and then we would head out to a break. So maybe I can start with the first question, which can be answered by Dr. Montini or our colleagues at NHSO in the audience. Low awareness was something that Professor Thavisak had pointed out, and also Dr. Montini had pointed out in terms of what we could do better to do better in terms of active case finding. Dr. Pisit has also pointed that out similarly, in the sense that if we are to progress, then we have to really ramp up and rapidly scale up our diagnosis process, and that could be done to start with probably with high-risk groups. So overall, from the time we started DAAs with sofledipasvir and SOF, that's in 2018, do we have figures as to how many people has entered the cascade as in an antibody testing, and how many have actually been treated and completed? Let's not calculate as we are at this point, but do we have a figure that how many actually entered from 2018, started antibody, and how many got treated? Do we have that figure? Dr. Montini, perhaps you, does anybody from the panel, do we know? I just want to get a sense how many patients are we actually losing in the cascade? That's the sense I'm trying to get. But do we have that figure?
I'm not sure Dr. Ratchapon is here.
Yes,
Yeah.
I think Dr. Ratapon can tell.
If Dr. Ratapon, if it could be shared.
So sorry, I'm not concentrated about your question again, please.
Right. So what I was saying was, starting from the time that we initiated DAAs, that's 2018 onwards, how many patients have started entering the cascade, which is an antibody test, to completing the treatment? How many is it? So that we have a sense of, the cascade of how many are entering and how many actually have undertaken treatment. Do we have that figure that could be shared?
I cannot complete your answer. We have the benefit package in NSSO in HIV positive only and PIVT only. So about 1 year we have I cannot remember about 3,000 access maybe. And only not much to access the treatment, but now we think it's better than last year. Then we have the software. The question of my staff talk about 900 bottles per month we access. I think this answer your question. Maybe someone help me. Yes.
Just for information, actually the cascade has not started yet, because we don't have the free screening in general population in terms of risk group. We have proposed screening for risk group, but that haven't been approved for reimbursement yet. So most of the treatment going to be by chance, that patient have abnormal ALT or have evidence of cirrhosis, and then they have been screened by chance, and then just found out that they got hepatitis C, and then just enter the cascade. So the cascade got to start after they know the hep C status, that they got hep C. So I think we need to get start the first step of the screening. That would be the most important challenging for the next few years, and I think as far as I know, during a few years of SOF Lite and SOF PEG driver, I think just about 4,000 cases treated, and until SOF has been approved and legally can be legally used after mid of February this year. So I think, but unfortunately, because of the COVID pandemic, so the treatment has been slow.
Yeah, thank you so much. I think I really appreciate it. We don't have to have the figures on top of our head. I think this drives the point that Dr. Pisit was pointing out, and Dr. Thavisak, yourself, Dr. Montini, everybody has been pointing out, Dr. Satawat, that we have to get on. We have to start really, simplifying some of the rules that we have for ourselves, so that we can serve our patient population better and we progress as a country towards achieving elimination by 2030. So I think that's one of the things. And many other components, as we have spoken, are really important, but then that everything starts with finding that person who needs the treatment. So that's the point that we are really trying to talk about here. I think Dr. Ratapon, also thank you so much for your intervention. We have a question in the chat box. I think this one particularly goes to Dr. Thangsawat. Says the question is the Thai study on the efficacy of soft VEL? No, this is not to Dr. Thangsawat, because this is about VEL. Is a Thai study on the efficacy of soft VEL published? Are there more details on the efficacy on HCV type 3B, especially those with cirrhosis?
You mean soft VEL, right?
Yes, they say soft VEL. Yes.
That was the part of the study Dr. Pisit just presented. I was part of the investigator in that. Yes, there are, but just a few cases of genotype 3B included.
Yeah, I agree that I think that study did not include enough cases of genotype 3B. So, and the response rate is, I think, was around maybe 80% or something, or less.
Yes.
Right. So the study results have been published.
Published already in Lancet.
Lancet Gastroenterology.
Yeah.
Okay. So Yuan from MSF Médecins Sans Frontières had asked this question. So maybe you could look up for that in the Lancet. If or after the webinar, when we share a thank you note to everybody, I think we can include a link to that publication so that you could download that and have a look. If there's a paywall, you can get institutional. Hopefully, you have institutional subscriptions to get access to that paper. Another question is from one of our colleagues from Ministry of Health in Cambodia, asking all the cases that are treated with DAA for 12 weeks, do they have to do SVR12?
Yes, and that also is a part of reimbursement scheme. So they got to have the HCV RNA testing before the treatment and 12 weeks after the off treatment 12 weeks.
All right. So Dr. Samle, so that's I think you have heard the answer. There's another thing around the DAA pricing in Thailand. I think Dr. Ratapon had shared in the chat earlier that SOFVEL for our Thai program is $750 US for 12 weeks. Is that correct, Dr. Ratapon? You're on mute.
Yes. The price is so very high because of only one company. We use the drug from the mainland. So it may be decreased in the future.
Thank you so much. So obviously having one to start with rather than having nothing is always good. But in the long term, definitely having more is going to be useful. For Thailand, I think hepatitis C drugs, in the case of sofosbuvir, was the first time when Thailand started using the WHO collaborative process of registration. And I think after that, there has been at least 3 or 4 drugs, including HIV drugs like dolutegravir containing regimens, has been used to assess to provide approval by our Thai FDA. So if that's the case, then if we have already started using it, then obviously there are a lot of WHO pre-qualified pan-genotypic regimen, except for Ravidasvir, which is in the process at this point of trials and applying for marketing authorization in Thailand. In Malaysia, that has been approved. Ravidasvir has already been approved in Malaysia. So we have a lot of options and quality, obviously, and also in terms of fast tracking the process, we can rely on the WHO collaborative process of registration, which we have already used. Anything else from the? I'm just trying to monitor also the chat box, and also be aware of the time of the break. Please, somebody just give me a ping in case if it's already the time for a break. The other thing is around people who are on efavirenz, for example, a HIV co-infected patient. And if we are using soft velpatasvir at this point only, what is their option?
That is the point, because software is going to be because the standard treatment for HIV. I think Dr. Nitya knows better than me, right? So the efavirenz got to have the problem for velpatasvir. So we need to communicate with ID specialists in terms of changing the regimen before starting software.
Dr. Nitya, would you like to just comment on it quickly?
Yes, I mean, I'm not consider myself HIV specialist, but I do agree that we do have options now, and that options can actually be managed outside of the specialist hands as well. So that would be my brief comment here. Thank you.
Okay, I see P. Jockey, you have raised your hands. Would you like to comment?
Yes, instead of using the efavirenz, we have the ripivirine available to replace that, and they can change the regimen to that to avoid the reaction from the soft. Yeah.
Thank you. So some I understand are being changed to dolutegravir for a short period of time. At the same time, some are switched to rilpivirine. So we have more options, definitely. Daclatasvir is in the pipeline here. BMS, Bristol Myers Squibb, have announced that it will not enforce patents on Daclatasvir in Thailand. So we have, I think there are pending registration dossiers with our Thai FDA. So the more that comes out, the more newer drugs like Ravidasvir comes on board, and also multiple suppliers that we have that can bid for our national tenders. I think that would drastically help in terms of accessing. But definitely the companies who have arrived earlier and are part of the process and have been supplying to the program and for the Thai patients, definitely they have done a great job, and we are very thankful to all of them. But for the future, we're looking forward to definitely having more. Are we on the break time now? I think it's 3:40 at this point. Han, can you just check? Sorry, I'm monitoring multiple screens, so it's like, okay, thank you so much. So we are going to go on a break now, which is a bio break. We call it a coffee break. If you have to catch something or get something or get a coffee, please feel free to do so. Before we do, are we going to take a photo of this screen? Can we do that? Can we have all the speakers unpinned for the time being, and then have everybody put on their cameras? Is it only the speakers, or is it everybody? We have at the moment 92 people, so you might have to switch 4 or 5 screens. Okay, yes, they say only speakers, so I follow the tech people who are behind, so only the speakers. Thank you so much, only the speakers. So we have all the speakers at the moment. If you are ready, please just, if you have done so, please Tilak send a message saying we're done. You're ready to go. Is it done? Okay, done. Thank you so much, everybody. Please go get your coffee or whatever you have to do. Please do it. And we will see you in the next 5 minutes. Please join before that if possible, where my colleague Jean-Michel would be waiting for you all to take on to the next session. Thank you all very much.
In Malaysia, we have more than 400,000 people suffering from hepatitis C.
The treatment in the past is so horrible to a certain extent.
There's actually a revolution treatment in hepatitis C, the DAA.
It's a major breakthrough.
But the issue is the cost, and not many people can have access to the treatment. It is a major public health concern.
只是医生跟我讲说，就是等新的药进来罢了啦，外国的新药进来马来西亚，等超过已经10年了。
We know the issues, we know the challenges, but how do we find amicable solutions?
Now we can tell the patient now, I have the treatment for you right now.
Together with agencies and other societies, we can make the impossible possible. In Malaysia, we have more than 400,000 people suffering from hepatitis C.
The treatment in the past is so horrible to a certain extent.
There's actually a revolution treatment in hepatitis C, the DAA.
It's a major breakthrough.
But the issue is the cost, and not many people can have access to the treatment. It is a major public health concern.
只是医生跟我讲说，就是等新的药进来罢了啦，外国的新药进来马来西亚，等超过已经10年了。
We know the issues, we know the challenges, but how do we find amicable solutions?
Now we can tell the patient now, I have the treatment for you right now.
Together with agencies and other societies, we can make the impossible possible.
should try to start. Thank you very much. So we are going to start now the second part of the meeting. You know, I think it's as we have seen in the video, one of the things with the DAAs is that it's really a revolution. You know, people who have treated patients before the DAAs know how complex and difficult it was, and that's why in the mind of many people, the treatment of HCV is still, you know, a tertiary level, very complex issues. But what we see all over the world is when physicians start using the DAAs, there is, you know, suddenly that enormous possibility opening of simplifying, reaching out to most at-risk population, which we know will be important in achieving the elimination target, and that we simplify, that we reach out to population that are most at risk or more vulnerable. And this is what we are looking at in this afternoon session. We are looking at how we can develop a program to reach out to this key population, and as well as involve the civil society into that elimination strategy. So the first speaker for this second part will be Nicolas Durier, Dr. Nicolas Durier. So his first advantage is I can pronounce his name properly. But Nicolas is also a medical doctor, and he created an NGO called Dream Development, who is a non-profit social enterprise. And with this organization, he's actually implementing the C3 study, which is a community-based testing and treatment for HIV, hepatitis C, and hepatitis B for people who use drugs and their partners. So Nicolas, the floor is yours.
Thank you, Jean-Michel. I will start to share my screen. Can you see? And I will put it as a presentation. Can you see and can you hear, Jean-Michel?
Go ahead. We can
okay, wonderful.
We can hear you.
Wonderful. So thank you very much, Jean-Michel, and good morning, afternoon, everyone. I'd like to thank the organizers for giving us this opportunity to speak about C3, which I will present on behalf of the team and all the partners involved. This is the outline of my presentation. I will start with goal and objectives. I don't have a slide on background. For the sake of time, I skipped that, and in fact, it was covered by the previous speaker. So just with the goal and objectives as a start, so C3 is designed as a study, so research study, on a model of community-based testing and treatment of hepatitis C, but also HIV and hepatitis B for people who inject drugs as well as people who use drugs. These are both former users, injectors, as well as active users, and it involves also their partners. There are many specific objectives in the study in the protocol, but broadly, we aim to demonstrate the effectiveness and safety of user-friendly community services in curing hepatitis C among people who use drugs. With this, advocate for expansion of community services and addressing some of what we believe are barriers to larger treatment with a program that is, as we saw, based on hospital service delivery and prescription by specialists. And then beyond that, catalyze really the access and use of affordable pan-genotypic DAAs in Thailand. And back in 2019, when we started the project, as we heard, the national program was still making use of pegylated interferon, ribavirin, and sofosbuvir for genotype 3. This is the design of C3. So we have a cohort study and an hepatitis C treatment sub-study. In the cohort study, we do testing of hepatitis C, HIV, and hepatitis B. This is again for PWID and PWOD as well as their partners. And basically among those groups, any adult that is willing to participate is eligible for the study. We do 3 monthly retesting for HCV and HIV, but we are moving in the new version of the protocol to every 6-month retesting for those negative. We use rapid tests for the different infections, and with those, for those who are infected, then we do, and so all this is on site, and for those who are reactive, then we do gene expert for HCV RNA, HIV RNA, HBV DNA. This is all on site. People who have HIV or hepatitis B infection are referred to their affiliated hospitals for treatment under the national treatment programs. Those who are non-infected or non-immune to hepatitis B are offered hepatitis B vaccination at the sites. And then for those who have HCV confirmed infection, then they are proposed to enter the HCV sub-study, where for those eligible, we provide sofosbuvir, velpatasvir. We have used MyHepAll since the beginning, which is provided as 12 weeks to everyone, regardless of the genotype, which we do not test, and regardless of the degree of liver fibrosis. That includes all staging, including F1. We actually do APRI just to then, for those who have signs of cirrhosis, do additional tests and check if they have compensated or decompensated liver cirrhosis. And we do not include people with decompensated liver cirrhosis in C3. We refer them for hospital-based management. These are the sites. As of now, there have been 6 drop-in centers run by partner NGOs that are named here. And soon, in blue also in the map, we will have 3 more centers from the Bangkok Metropolitan Administration. These are community centers run by BMA, so these are government partners. And 1 new DIC run by a partner NGO in TAC. The DICs are affiliated somehow partner with hospitals or research centers. That includes 3 district hospitals that participate and that mobilize actually young non-specialist physicians to go to the drop-in centers to provide hepatitis C treatment, to manage the treatment. These are pictures from the field. Up left, a typical community centers, drop-in center, in which up right, we have in just 1 single room, fitted all equipment needed for the C3 clinic. Bottom left, you see we have a centrifuge machine. We do the rapid test on site. And also, as I was saying, the gene expert testing on site. This is done by the nurse. The nurse is present every day and does most of the procedures. Here up left, collecting information on the case report forms. Upper right, this is hepatitis B vaccination. Bottom left, the physician comes once per week to provide treatment. And bottom right, you can see this is a young physician, non-specialist at Chana District, from Chana District Hospital, that comes to manage treatment. Now we'll cover some of the results, and these are pictures of participants who've been cured and who have consented, of course, to use these pictures. These are the enrollment update as of 31st of August, and across all sites, you can see we have included in the cohort just about 1,500 participants, and in the hepatitis C treatment component, 708 participants. These are patients' characteristics. This data set is up to June 30, so it's not the exact total number of enrolled patients, just a smaller subset. And the median age is 42 years old. We have a large majority of men, just only 14% are female. We have people who have other risk groups, risk factors for being infected with hepatitis C. That includes 12% men who have sex with men. They do also report drug use, mostly non-injecting, eyes, poppers, and substances like this. Now, in the whole cohort, there are 35% of the participants who report current injecting drug use. So this is injecting. And we have 39% who report previous injecting. This is a total of about 75% of the participants who have a history of drug use. And also 36% report alcohol use of various levels of consumption. Now, in terms of HIV, HBV, and HCV, first with HIV, so we have 38% of the participants who are HIV infected. Now, most of these participants have actually known that they were HIV infected. Majority of them, 94%, are on ART. Some have dropped from care and are not on ART. We have tested the majority on site for HIV RNA, not everyone, and we are moving to do that. And in 89% who have been tested for HIV RNA, 85% are HIV suppressed. Those who have not been tested are more likely to be suppressed, perhaps had results already available and were not tested. Now, with regards to hepatitis B, 5.5% have chronic hepatitis B, and this is quite consistent with prevalence in the adult general population in Thailand. 40% of those are on treatment, and we follow here the approach and management under the national treatment program. We have 66% of the participants who are non-immune and non-infected or non-infected. And among those, again, we offer hepatitis B vaccination, and the vast majority have started and accepted vaccination. Now, on the right, with the HCV component, in that cohort, we have 68% of the participants who have HCV antibody. Among those, 84% are confirmed viremic with active HCV infection. In the whole cohort, we have then 57% of all participants who have confirmed chronic hepatitis C. Among those, 9% have APRI above 2. And in terms of co-infection, then in the HCV participants, we have just about less than 50% who are also co-infected with HIV. This is not the HCV treatment cascade. These are data up to 10 June. I'm sorry, these are different subsets of analysis, but it's almost everyone who's been included so far in treatment. As of then, we had 757 patients who were diagnosed with hepatitis C. 737 were eligible to receive treatment. A few were ineligible, had received treatment before, were on treatment, and some reason arrived in C3. A few had decompensated cirrhosis, were not eligible, or the condition that made them ineligible. 664 did start treatment, and here for the majority or a good number, it's actually people who were HIV, who are co-infected with HIV, are on efavirenz and do need to go to their hospitals to switch from efavirenz to ripivirine, which we discussed just before. So that's a bottleneck. Among those, then 549 have completed treatment. Among those, 445 have attended their SVR visit. 424 are confirmed cure, have achieved SVR 12, which is a per protocol cure of 95.7, intent to treat among all those who started treatment of 92%. As lessons learned, there is a very strong interest. It has shown a very strong interest and high uptake for this community-based testing and treatment care model. We have people who come from many provinces and travel long distances to reach C3 sites. Those who are HIV or hepatitis B infected are referred for treatment under the national program. Some of the people with chronic hepatitis B have been diagnosed in C3 and engaged in care. Some people who dropped from HIV care are re-engaged in HIV care before they start Hep C treatment. It has shown that SOF-VEL is safe and effective in community-based care among PWID and PWOD, including among people who have active use, with a per protocol SVR of 96 almost %, intent to treat of 92%. We have had no serious adverse event related to the study medicine. It shows clearly that non-specialist physicians can successfully manage hepatitis C treatment. And we note, as it was discussed before, that SOF-VEL is now included in the national treatment program. We do hope that C3, among the efforts of many, many others, have had a contribution in supporting the inclusion of SOF-VEL in the national treatment program. Now, as future plans, well, I will actually start with an updated sort of current context. And these are here graphs borrowed from the CHAI HCV Market Intelligence Report that was just released. We see on the upper left the evolution of the price of different combination over the past 5 years, substantial reduction of SOF, DAC, and leadipasvir, a bit lower for SOF-VEL just because it's used less than the other. On the right, we see the price of SOF, DAC here in countries, in different countries in the region, and we can see the very wide variations in pricing of the exact same molecules in different countries that illustrate very different dynamics in the different countries. As we heard from Dr. Ratapon, SOF-VEL in Thailand is priced at $750 per treatment course. We have only one generic soft VED that is approved. Other companies have filed for approval but have not yet received that approval. And then with Daclatasvir, it's just waiting approval, and one company in particular has waited for 2 years for approval. So it's not yet registered, it's not yet among the options for the national treatment program. Now, in terms of future plan again, so we are striving to have hopefully more impact, continue to have more impact. We plan extension of C3 in Thailand. Again, few other sites will join. In a protocol that was amendment that was just approved, we will soon start a component of STI testing and treatment. We also consider incorporating testing and treatment of latent TB as well as HIV PrEP in the future version of the protocol. We also do work hard and discuss with different partners to extend C3 regionally in countries in Central and Southeast Asia to here build a broader base for demonstrating the importance and the success of this model of care and building advocacy at the regional level. In terms of medicine, and I'll close soon, in terms of medicine, again, there is a huge need to further catalyze increased access to needed HCV medicine. We do plan, actually, in the extension of C3 to use Sov-Ravidasvir, which was discussed by Dr. Tonsawat and others before. It's developed by FARCO in collaboration with the NDI, who are committed to low pricing. In the STORM trial conducted in Thailand and Malaysia, it has shown, as it's been published, very high efficacy among all groups, including patients with genotype 3 and with cirrhosis at 96%. There is no interaction with efavirenz, which is again a bottleneck for use of Velpatasvir. And we believe that the inclusion of Sov-Ravidasvir would be a great option for national treatment program in Thailand and in other countries. To close, with regards to advocacy, we want to continue to advocate for extension of community services as part of the national treatment program with training of CBOs and those services, perhaps accreditation and funding for these services. Wish to advocate to allow any medical doctor to prescribe DAA under reimbursement by the national program, to extend eligibility to all stages of liver disease, not only F2 and above, but including F1, include people with substance use, and that means also people with active substance use. And in the national programs, it may be that people with substance use, history of substance use, are eligible, but perhaps not active, as well as addressing stigma in the hospital care settings. We again really strongly advocate for registration, prompt registrations of more DAs to increase competition, reduce the price, and increase finally funding for the viral hepatitis program. I will close with acknowledgement of founders and partners, and thank you very much for your attention.
Thank you, Nicolas. I think yes, your demonstration is important. The tax shifting, the simplification. As I said, we are coming from a background of very complex disease because of the treatment before. And I think, this is very important. We see that in every country. We've seen that in Egypt, we've seen that in Cambodia, we've seen that in Malaysia, that, successful national programs need to have this kind of demonstration. I think it's normal that we want to reassure physician, Ministry of Health and decision makers that it is possible to shift tasks, to simplify. And so I think you've demonstrated that, and it's great. We were supposed to have Dr. Anshale also discussing about specific groups, and unfortunately, as Githan has said, she can't attend the meeting. And I would like to ask Dr. Nitaya from the IHRI to cover a little bit for her. I think you have some words to exchange with us, so you're welcome, please, Dr. Nitaya. Sorry I don't have your bio, but I'm sure everyone knows you very well.
Thank you very much. Can you hear me well?
We can hear you. We can't see.
Yeah, I'm trying to share my slides. Okay.
Yes,
I'm sorry, the internet was a bit lacking. So thank you very much. I probably would like to share some idea which are mainly based on what all the previous speakers have already established in Thailand. So for us here, we are planning for the key population-led same day HCV test and treat demonstration project in Bangkok. And I only have 3 slides that I will use to guide this idea by saying that because IHRI as an institution working mainly with key populations in HIV field, we have seen an explosive Hep C epidemic among HIV positive MSM. And what is shown on this slide is data from the largest acute HIV cohort in Thailand, which you can see that this is a cohort of around 600 people and 94% were MSM. And we have seen a dramatically increase in HCV incidence among these people who were follow up long-term in the cohort from around 1% per year to now almost 5% per year. And this is what you can see, that the association is mainly with the use of crystal meth. And you can see that 80% of these HCV incident cases did not report any injection history. So this is a new epidemic that we have seen, we have learned, we have heard from the European country, the Australian colleagues for quite a few years now, but we now have a documentation that this is also an issue, a burden of this disease in Thailand. And at the same time, because we have been working quite a lot over the past 6 years in establishing the key population-led HIV services with our community-based organizations colleagues in different provinces in the region, that we when we learned from that data from HIV acute HIV cohort, we started to think about now again integrating Hep C services into these key population-led health services clinics in Bangkok first. And I may have to tell a bit of the short story to the audience here, because I don't think everyone here is very familiar with the key population-led health services concept. But this is a service delivery model in Thailand that we ask our KP-led organizations to be the one who design the service and then be the one who deliver or co-deliver health services. And that include delivery of HIV counseling, blood collection for HIV testing, as well as sample collection for gonorrhea, chlamydia testing, as well as the giving out of medications prescribed by doctors in the country, and that include the giving out of ART, giving out of PrEP and PEP medication. So this is the roles that are already legalized in the country and has already been in the certification process by the Ministry of Public Health that KP lay providers can do. So clinical roles that KP lay providers can do. You can see that that's has over the past 5 years, focused on HIV and gonorrhea, chlamydia, syphilis. But now we are adding hepatitis C component into the service by starting just by adding anti-Hep C testing into these clinics. And we started with 2 clinics in Bangkok, which is Swing Clinic in Pat Pong area and Rainbow Sky Association of Thailand, or RSAT Clinic in Ramkhamhaeng area. And since late last year, November last year, until now, until July, this year, we have tested more than 4,500 people and found 107 anti-Hep C positive cases. And with this like very simple cascade, you can see that among those who tested positive, the majority of them are MSM, although clients coming into these KP clinics can be MSM, transgender women, or even heterosexual clients. And you can see that only 17% of these people were those also co-infected with HIV, but 65% of these new Hep C cases, newly diagnosed Hep C cases, are those who are PrEP users, who are current PrEP users. So this is another population that we may need to focus on in HCV program in Thailand. Not only HIV positive MSM, but also HIV negative MSM who are at high risk of getting these bloodborne viruses, including Hep C. Looking at the cascade here, you will see that with this 2.5% prevalence that we can say, only less than 50% of them receive RNA testing, and this is mainly through the referral to C-free sites in Bangkok, which, as you already hear from Dr. Nicola, it's 3 sites at the same time that this testing has been implemented. And among those 82% who tested RNA positive, you can see that only 3/4 of them had already started the AA. So we can see like a large gap here in from like diagnosis of Hep C in the KP-led clinic, and then the referral to get Hep C RNA confirmation before you can start treatment, that you lose like half of people already from the cascade. So that's kind of the main rationale behind why we are thinking of doing this demonstration project to look at both effectiveness and implementation outcomes of the key population-led same-day Hep C test and treat in Bangkok. We think we will start with Bangkok with limited funding and resources, but if shown to be feasible, then we certainly would want to expand this to other provinces where we can expect to see a very similar epidemic of hepatitis C. And so here, you can see that because these community-based organizations already have the gene expert machines, and we already discussed about how to use gene expert machine at its maximum benefit and not only limited to certain disease categories. And these CBOs already used gene expert for gonorrhea and chlamydia testing and for HIV RNA testing as well. So we'll build on this infrastructure to allow anti-Hep C testing as well as the confirmatory HCV RNA testing to allow on the same day, so that the treatment can happen on the same day via teleconsultation with a physician. So we do not expect a physician, even though that could be a specialist or a GP, to be present in the KP-led clinic, but we will use the teleconsultation to allow same-day prescription and same-day giving out of the medication to happen in the clinic. And by looking at this, we will be focusing on the effectiveness endpoint, which is the HCV cascade, comparing this to prior to this implementation using the interrupted time series, as well as looking at the Hep C reinfection rate among this population. And the implementation outcomes will include acceptability, feasibility, as well as fidelity of these Hep C test and treat services in the KP-led clinic. And that's the end of my presentation here. So thank you very much.
Thank you, Dr. Nitaya. No, I think, again, I'd like to insist on the fact that these new DAAs open up the perspective of what we can do in terms of reaching out to population, simplification, task shifting. And it's great that you are trying to do that with this program. Our next speaker is Chalamsak Kititrakul, who we all know as the Joke. So Joke works with the AIDS Access Foundation and is a coordinator for the Access to Medicine campaign. Joke is a strong voice and advocate for the civil society role, and I think in addressing this HCV pandemic, it's very important that we engage with the civil society, as we know we need to bring patient to treatment as well as treatment to patients. So it is important also as we are reflecting on where we are today in Thailand, to look at the contribution and of course so far, but also the opportunities that are there for the civil society. So thank you, Joke.
Thank you, Jean-Michel, for your kind introduction. And good morning and good afternoon, all the participants. It's my honor to be here to make a presentation on the roles of civil society that give the contribution to access to the hepatitis C treatment in Thailand. And if you don't mind, I will share my screen. Can you see my screen right now?
Yes, we can, and we can hear you well.
Yeah, thank you, Jean-Michel.
Can you put, yes, thank you.
Yes, I'm here on behalf of the Thai Civil Society and also the network of the people living HCV in Thailand, that we have advocate for access to hepatitis C treatment quite a long time. This is quite stunning when before we start our advocacy. As you've seen, when Gilead introduced their Sofosbuvir, that's the trade name is Sovaldi in the year 2012. Its cost is very expensive. It's about one tablet equal to $1,000. This is a message that we use to communicate with the media and also the public, that one tablet of Sofosbuvir is equal to one iPhone. So it's quite stunning price, and it's shocking, not only for the civil society and also for the doctors and the public health workers as well. It's too expensive and no one can access to this medicine. So what we have done in the last 7 or 8 years ago, we have worked on the access to Sofosbuvir before the year 2015. But it is the official campaign kick-off on the 20th May 2015. We do the demonstration in front of the Ministry of Public Health, calling the policymaker to make use of the legal mechanism that's called compulsory licensing to import or locally produce Sofosbuvir at affordable price. We over there, try to meet the policymaker at the Ministry of Public Health, asking them to do so. But anyway, at the end of the day, they did not decide to make use of compulsory licensing or CL once again. Thailand have used this mechanism, 10 years ago in the year 2006 on the HIV, the medicine, on the heart disease medicine and cancer medicine at that time. But this time they are reluctant to use the legal measure once again. But anyway, they decide to set up a specific agency under the DDC to take care of these issues. Anyway, we still move going on, calling the government or even the society to do something. We try to make use of our patent law to challenge the patent application that filed for Sofosbuvir in Thailand. We have firstly at the office of the patent office, find the information to the patent examiner to show that the application for Sofosbuvir is not qualified to get the protection under the patent. This is a huge pile of documents that we have prepared. It's the scientific data and also the legal information to prove that all this kind of application is not is unmerited to get the approval, to get the patent protection. Every time we over there, 5 or 6 times at the office of patent, we do some action calling attention from the media and from the public as well, try to raise awareness that this is an unfairness on the patent protection on the Sofosbuvir. This is picture to show you that how the multinational drug company make use of the patent to monopolize the market. This is the tactics that the big pharma use all the time. We call evergreen patent. One drugs have not only one single patent application. For the case of Vosavir in Thailand, they file all 14 applications on one drugs. And each application, if they granted for the patent protection, they're going to have monopoly for 20 years. So each lines of this in this slide show one application or the 14. If all of them are granted, the monopoly will not limit only 20 years, which will extend to 30 years. But anyway, we make use of the law and file the patent opposition, 5 of them, as you see in the raised asterisk. And until now, Gilead decided to discontinue the application for 5 of them, as you see in the gray asterisk. But anyway, we, in addition to the make use of the patent law to oppose the unfair patent application and also calling the government to make use of compulsory licensing, we also do the other thing as well. We build out the capacity for the people living in HCV network to let them understand what is health literacy or hepatitis C, what is HCV, what is the treatment, what's the barrier, why the price is expensive. And on that, we get feedback from the field as well. When this group go to communicate and advocate at the local level, it's coming back. They have some of the other challenges and barrier as well, in addition to patent barrier. In addition to capacity building for our organization, partner organization, we're also building the alliance with the other as well. As we know that we can work alone, we work with the GI doctor, hepatologists, that to make them join with us to advocate for access to the HCV treatment with the HCV DAA. And also we also work with the foreigner NGO and civil society as well, like the DNDi. We support their clinical trial to make use of sofosbuvir and ladivosbuvir for the HCV treatment, and also like the TWN, MSF, and the groups that call Make Medicine Affordable to file the patent opposition, challenge the unfair the patent application on sofosbuvir. And also we work with the other civil society in Malaysia, in India, in Vietnam, in Indonesia as well, to share the lesson learned, share the information, what's going on in Thailand, what's going on in the country, to find collaboration across the country. We also work with the policymaker in addition to the patent issue. We work with NHSO, that the responsible for the Rural Health Coverage Scheme, National Agent Darkness Committee, and also Department of Disease Control as well, trying to make them to change the regulation, to amend the guideline, and to simplify those kind of legitimacy criteria to allow the people who can access to diagnosis and treatment for the hepatitis C. We also had a meeting with Gilead as well, with that CEO, to do the price creation, for Thailand, because the price is so expensive. But anyway, at the end of the day, they just consider that Thailand is the middle income country. You are rich enough to buy, that price. And on top of that, we also do the policy dialogue with the local production, with the local manufacturer for the registration of the generic version in Thailand. And also, we also go to meet with the generic manufacturer in India as well, try to convince them to come to Thailand to make the registration of their product in Thailand. So what we have done for the last 7 or 8 years. But anyway, the turning point is the compulsory licensing that announced by the Malaysian government in September 2017. That makes the game change totally, As the Gilead know that Malaysian government want to use the compulsory licensing, they changed their mind. They announced to issue the voluntary licensing to Thailand, Malaysia, and also the other 2 countries as well, that allow them to locally produce or even import the generic version of sofosbuvir and the other HCV DA medicine to Thailand. So that make the change. This is the international conference that happened in Marrakesh in the year 2018. This is a reward that we give to representative of Malaysian Ministry of Public Health, that they have to take their political will and make decision to issue the compulsory on sofosbuvir, and that makes the other country can get benefit out of this. So after Gilead announced to issue the voluntary licensing to Thailand, the decision making has been changed totally in the few days, that they include sofosbuvir and sofosbuvir-ledipasvir in the national list because the price is going down rapidly. So it's make Thailand can make use of it. And this is the estimated cost saving and access, that how much we can lower the price, how much we can increase the access. But anyway, with the same amount of budget that provide for the pegylated interferon-based treatment, we make use of the 13 million baht, $13 million per year for pegylated. We can use the same amount of money to treat the people with the soft pegylated interferon and ribavirin, and also soft lady. But anyway, this is the estimated cost saving and access. But look at the reality; it's not like that. This is information, when Thailand have soft and soft lady available in the health coverage scheme from April 2018 until February 2020. So the asset is quite low, much lower than the estimation. Just until the February 2020, it's only about 6,500 people can treat it by these two regimens. So they have the other barriers where that not a lot of people can access to the pathogenic HCV DAA. And this is also one of the reasons to explain what's going on. It is a study done by TP Plus, the Thai Network of People Living HIV/AIDS. This is the way how they convince their colleagues and their HIV fellows go to make use of the service available. This is how to test the policy. The policy has been endorsed, but look at the practice level, it's not like that. HCV DAA is available, pegylated interferon available, or even they have the phosphate is available. But we're going to see from this cascade that just only 5% of the ones who are diagnostic have their HCV positive to get the confirmatory test. Only 5%. So we have no question as to why the access to treatment is so low. This is the situation happened, in the year 2015 to 16. But until now, the situation hasn't been changed much. As the other presenters and make it as well, that we have the problem of bottleneck to get confirmatory tests for the HCV infection. And about the price, I borrowed this graph from the Treat Asia. It's an old data. For now, I think the price of the HCV DAA or for the medicine much lower than this. But you look at Thailand, software has been included in the National Health Insurance Scheme in January 2021, just very, very recent. But anyway, to look at the price that Thailand have got is about $260 per bottle, compared to the price in India, just only $162 per bottle. So the price the price is so high because they have no competition. It's monopolized by one single generic company, Mylan. So we have the generic company come to Thailand to make the registration in Thailand. But now we have some good news. GPO, the government pharmaceutical organization, is trying to find the registration for software with the Thai FDA, and we expect that by the end of the year, it's going to be approved by the FDA. So we have the additional generic version of the software available in Thailand, and we hope that the price is going to be lower. So I would like to make the conclusion that what is the job or what we need to be done next. As many guest speakers earlier mentioned, that we need to simplify the diagnostic and treatment in Thailand. And also we have to diversify the accessible option or the HCV confirmatory test at the lower price, that to unlock or to overcome the bottleneck that just only limited number of people can get the confirmatory tests. And also we have to remove the other barrier as well in terms of eligibility criteria required for diagnosis and also the treatment as well, as Dr. Presit had mentioned, and also Dr. Adisa has mentioned also. One last but not least, I would like to mention that we have to encourage more competition of generic version of software in Thailand to make sure that we can lower the price much we can, so we have increase in access, and also to use the budget for the other option of the analysis as well. So that the conclusion of my presentation. Thank you.
Thank you, Joki. So I'm aware we have totally overshot the time for the meeting, but the purpose of the meeting we wanted to organize with our partners was to restart the conversation in Thailand on HCV treatment and access. And I think we have achieved that. So I'm sorry if some of you have to leave now. I hope you can stay a little bit longer as we hear our last speaker. We won't take many questions, and then I will ask Giten to prepare maybe a 2-minute statement as a conclusion. I'm sorry we can't have more of a dialogue, but again, I think we are all committed with our partners to continue that conversation and organize another meeting as quickly as possible. So the next speaker is Dr. Bharat Bhushan Rewari from the WHO Regional Office for Southeast Asia. And very quickly, Dr. Rewari has been involved in the ART program right from the days of the conceptualization and in India. And so we are going to now listen and get from him what he feels. We were talking, there was a conversation in the chat about regional collaboration. And I think definitely this is something that WHO can bring to the table. If we look at what happened in COVID-19 response, we can see that waiting for the central response to come to you is never going to work. So I think regional collaboration, whether it's on HCV, on COVID, on other issues, is more than important. South-South collaboration is something I've been advocating a lot. Because if we look, for example, at COVID-19, India by itself and China by itself have brought more response to the COVID crisis than the US or Europe together. So, South-South collaboration is something we really need to start considering instead of always looking at the center if we want to solve some of our problems in the regions. So, Dr. Rewari, how can WHO, help us do that?
Thank you, Joe, Michelle, and organizers. Can you hear me clearly?
We can hear you well, and we can see your presentation.
So, thank you for inviting WHO to be part of this very important and informative session. And thanks for your opening remarks on basically the regional cooperation. So I'll briefly touch upon what has been WHO's role. We know that World Health Assembly started this issue of looking at the hepatitis agenda in 2010. And in 2014, World Health Assembly, it called for development of a global strategy for viral hepatitis. And this was in 2016 that World Health Assembly approved a global health sector strategy for viral hepatitis along with HIV and STIs. And we all know that the goal was basically to eliminate viral hepatitis as a major public health threat by 2030, which essentially means a 90% reduction in new infections and 65% reduction in mortality through 5 core interventions. I think that is very clear. In line with the global health sector strategy, a regional office for Southeast Asia brought a regional action plan, basically which was an actionable framework governed by principles of human rights, equity, universal health coverage, and evidence-led actions. Broadly, the framework of support from WHO has been on 3 pillars: planning the response, driving the response, and evaluating the same. On the first pillar on planning the response, WHO worked basically on getting the political leadership, community engagement, moving to champions and partnerships, moving further to strategic planning, basically defining the epidemic, getting the countries to make comprehensive national plans, and then moving to the second point on improving access to drugs and diagnostic and simplifying service delivery, and with clear indicators for monitoring the impact. WHO's technical support is in form of different guidelines which started right from 2015. I will not go into details of each guideline, but in 2020, I would like to emphasize that WHO brought in the PMTCT recommendation on antiviral medicines. And this year, there were guidelines on hepatitis C self-testing and interim guidance for country validation of viral hepatitis elimination. Besides the guideline, WHO is also supporting countries by providing different implementation toolkits, examples from champion countries on good practices, lesson learned from some of these countries which can be extrapolated, and also supporting through regional office and country offices of WHO on updating the country's treatment guidelines, getting the national strategic plan, supporting on supply management, testing policies, and strategic information. One of key components basically that WHO brought in is evidence-based guidance on simplified service delivery. I will not be able to go into the whole details, but the 5 key principles of good service delivery are simplified standardized algorithms, which basically focus on use of quality rapid test, prompt or reflex RNA testing, non-invasive staging, use of pan-genotypic regimen, and one-step test of cure. The second good practice that has been documented is strategies to strengthen linkage from testing to care and treatment, which includes use of trained peers, lay health providers. We know use of clinician reminders, provision of testing as a part of integrated service. The third good practice that has been documented is on integrated testing and care with other services like HIV, harm reduction services. Very important documentation has been on decentralization of testing and treatment to primary care center, harm reduction sites, and the evidence has been shown that these even decentralized level with task shifting to non-specialists, there has been similar SVR 12 compared to specialist care, and we just saw the evidence from the CFRE study on the same lines. Some of the new diagnostic innovations which are in the pipeline, the HCV self-testing guideline have already been released, but again, the focus has been on role of point-of-care HCV viral load testing in improving the linkage care, use of dried blood spots for viral load testing, and diagnostic integration using multi-disease platforms for HIV, HCV, RNA, and HBV DNA. The regional office has been supporting countries to develop costed national action plan, and in 2019, we had a very useful meeting where national program managers and WHO focal points from all 11 SEER countries came to that meeting. And there was support from all 3 levels of WHO headquarters, regional office, and country offices, along with our partners like CDA Foundation, FIND, CVAP, Treat Asia. We had involvement of community group of people who inject drugs and costing experts to guide the country on the unit costing and how to develop the costed plan. And this was a 5-day training basically on site where countries developed a framework of their cost reduction plan. I will not go into details of the day-wise agenda. Advocacy through demonstrating cost effectiveness has been a key component of the WHO work. And if we see, this was a recent documentation from regional office which showed that use of soft DECLA and soft FELPA both are not only cost effective but cost saving also in long term, and that led to gain of 4.4 years of QALYs. Now the CRO is also working with Treat Asia and other partners are improving access to diagnostic, because we have seen that the cost difference between India and many other countries in the region is huge, and how do we address these bottlenecks on registration and patenting? Similarly, as was pointed out in one of the presentation, WHO, CRO, and Wipro also working with the partners like Vidral Institute in Australia through NHAP grant, basically on developing an operational guideline. We know that there are 10 core indicators for monitoring and evaluation, but how to get the information? So these operational guidelines will assist countries in collecting, monitoring, and evaluation indicators. We have also been working on awareness and advocacy, because we know that only 10% of those with hepatitis are aware. So various initiatives like World Hepatitis Day, Goodwill Ambassador with the Cine personalities, partnership with professional organizations. WHO has been working with not only with Alliance, FIND, Treat Asia, but also working with hepatologists. And WHO is trying to actually build a link between hepatologists and public health specialists through participation in various conferences like APASAL, EASL, and INSAL. We are all aware about the progress report that has just been released on the global health sector strategy. And this report highlights basically not only the progress, but also signals the need for renewed effort to reach 2030 targets. And if you can see, there has been a revision of the burden estimate, with the hepatitis C global estimate to be around 58 million and hepatitis B around 296 million. What is also coming out of this, that just 21% of those with HCV has been diagnosed. Though the number has increased significantly from 1 million in 2015 to 9.4 million, still it is 21% diagnosed and 62% of those diagnosed being on the treatment. Similarly, of the progress on hepatitis B has been that just 10% of those with hepatitis B know their status, but an achievement has been in terms of reduction in the prevalence among less than 5 years old, and these 2020 targets of less than 1% positivity have been achieved. Based on this global progress report, the progress and the gaps, now the WHO is trying to close these gaps to 2030 elimination target, and World Health Assembly 74 in May 2021 adopted decision requesting WHO to develop global health sector strategy. I would just like to highlight a little bit that the global health sector strategy is being developed now from 2022 to 2030 will be integrated. 3 disease specific directions will be there, but these will be the integrated strategies, and the overarching principle will be to leverage the strength of the primary health care, universal health coverage, and also these integrate for quality and efficacy. Quality, equity, innovation, and people-centered approach will be the key of these strategies all along 3 directions. And community-driven approach will form a major component of these strategies.
Dr. Hemwari, if we could go to your conclusion.
Yeah, just quickly. Similarly, the regional action plan for 2026 will also be developed by the regional action. New WHO elimination guidelines for country validation of elimination of hepatitis have been developed, and these are being actually piloted in countries across, and Thailand is one of the countries which has agreed to pilot these validation elimination criteria. Triple elimination of mother to child transmission is another opportunity that we are trying to leverage. So to summarize, WHO has been focusing not only on technical document, but also on advocacy, supporting pre-qualification, diagnostic and investment case. Something, and often because these guidelines continue to evolve, we are also coming up with the DAA regimen for children, adolescent, and updated hepatitis B treatment guidelines. Thank you. I would like to acknowledge the support from Dr. Philippa, Dr. Nicholas, Dr. Mukta, and my colleague, Dr. Nabil. Thank you.
Thank you so much, Doctor. So in helping to improve the guidelines, I have a question from close to Dr. Nitaya. So we know that it's a common issue, the drop between HCV serology and NAT testing. Do you have any idea how we could improve that? Any thoughts on how we could improve that? Something that springs to your mind from your own experience?
Yes, I already put some of my answers in the chat box, but just to mention again briefly, I think that it's because of the because of the limited eligibility criteria for DAAs in this country that would not allow us to just refer any clients to any public hospitals, because we know that for MSM populations, we really want the immediate testing and immediate treatment to halt the transmission. And by referring clients to public hospital, we know that they would not be put on DAA. So why would we want to refer them? And that's why our main strategy now is to refer clients to C-free study, where we know that immediate treatment would be available. But because of the limited slots each day that the study can afford to enroll new participants, that's why we have this like 50% gap in people diagnosed with anti-HCV to get confirmation with RNA.
So removing the barriers, the existing barriers, making sure DAAs are more available. What about self-testing? Do you think it has a role to play?
if I may start first, I certainly believe that having options, and this is options for testing, options for treatment, certainly is a way to go to address any health conditions in any country. So similar to HIV, we know that self-testing is not replacing facility-based testing, but it increased options for people to be aware of their status. So that would be true for Hep C as well. And by using the point-of-care RNA testing, and this again repeat many speakers before, that we can certainly make a one-stop service for Hep C to be able to be feasible, and it's not like any additional investment in that sense, that we can demonstrate the feasibility of this like same day test and treat for Hep C.
Any other comments from the panelists? Nicola?
Well, I would quickly say that self-testing, HCV self-testing, antibody self-testing is great and really needs to be deployed. But here also a bottleneck that we see with what Dr. Nitaya mentioned is the gap between the antibody testing and the RNA. And one bottleneck exists here in the C-free capacity of absorption. But what we need also is much greater availability and affordability of molecular testing. So I think I would emphasize that, as Dr. Nitaya said, yes.
I think that remains a gap everywhere.
It remains a gap. Yes.
Yeah, not just in Thailand, everywhere. This is really a big gap. I don't know how to address it, but at the moment there are very little affordable options, and that's probably one of the biggest gaps at the moment. Because DAs are available, it's just a lack of competition. But in terms of molecular testing, we lack a little bit options, especially affordable one. There is another question also from Dr. Luhmann again about any specific approaches to find patients that maybe are not a bit less obvious. So maybe people that have had a blood transmission before, IDU users who do not necessarily, who have a normal life, because many of them actually have. So any specific approach that you would recommend for these groups? So the question is, it's always difficult to find and identify people with an historic infection. Are there any specific approaches that have been planned to identify these patients?
You're talking about patients who have a history. Jean-Michel, clarify that again.
Like you are reaching out to specific groups, but there are people who actually do not associate with these groups and yet are at risk. So any specific option? I think Professor Tawesak wants to maybe intervene on this.
Screening campaign.
I can
go ahead.
Partly answer on this. Actually, the DDC has some, for the guideline, we have defined the specific risk group, but as you know, as I mentioned earlier, that the main problems is that we don't have the reimbursement for anti-HCV screening. So I think if we can, get over with that barrier, so then that's going to be the best, because actually for the basic, screening for, we have offer, for example, blood sugar screening in the people older than some specific age, every year or something. So then just include this one-time testing for HCV in this risk group, which we have defined already. So I think hopefully by next year we can get over with this barrier and then bring all of this issue in, and then we can find new cases fit into the treatment cascade.
Thank you.
And actually, regarding the confirmation of hepatitis C, so and WHO has included the reimbursement for molecular confirmation before the treatment and after the treatment, $300 for the confirmation test.
Thank you so much. So I think we'll have to stop now because we've overshot by a long time. So I will ask Giten to, we won't have time to engage more in a conversation, but I will ask Giten to do a 1 or 2 minute conclusion. Thank you. Thank you everyone for your contribution. Very interesting.
Thank you so much, Jean-Michel. And starting, some people have missed the beginning of our conversation, while some has been there throughout. So thank you very much either for joining or for staying on throughout. So overall, for Thailand as a national program or as a country, we have been doing a very, I would say considerably well in terms of leading the response, and from 2012 onwards. And those days we did not have anything but pegylated interferon. So we moved on, and then 2018 we started getting DAAs, and then now we have of course a pan-genotypic regimen with limitations, of course, as a single supplier, a single regimen that is available. PLHIV who are on antiretroviral ribavirin have to do switching of HIV regimens either temporarily or permanently. Those things are in question at this point, but we have been fairly to an extent working towards a much more positive, progressive environment in response to hepatitis C. A lot of newer ideas coming out. Great to hear back about the civil society representatives taking the path of intellectual property related laws to make sure that access is enabled in the country. And also some of the innovative ideas around working with PLHIV, PWID, people who inject drugs, people living with HIV, and more innovative ideas around same-day test and treat for hepatitis C. Overall, one of the things that has come consistently across, and I'm sorry, we are not having the time to do an open forum discussion, but I think we will absolutely be able to bring back some of the people within Thailand physically. And as you know, the next World Hepatitis Summit is going to be in Bangkok in June of 2020, and hopefully we will be able to merge in a lot of what we start today and in between till June of 2020, and be able to have or showcase some of our successes in the global platform. One of the things that, again, I would like to reiterate is we need to relook at some of the criteria that we have at this point on initiation of treatment, which includes hepatitis C viral load of 5,000 IU/ml, fibrosis staging of F2, treatment to be provided only by specialists. So those things are some of the things that needs really reconsideration in terms of what we have in our guidelines at the moment. We need to move on with active case finding. That's very, very clear with Dr. Tavisak, Dr. Pisit, everybody talking about this. Some of the avenues have already been pointed out by Nicholas Pijoki as to what he has been doing. Dr. Nitya as what she's planning in terms of initiating a same-day test and treat. This is an idea which we have been floating for a long time. Unfortunately, we haven't been able to get the kind of funding that we needed, although it has never been a large amount, but I think hopefully we'll be able to get through it this time, at least in 2 sites in Asia, both in Zero. So that would be great if it all goes well, and we'd be showcasing different models, 2 different models of how to do same-day test and treat for hepatitis C. We need to get newer drugs, both in terms of regimen and also in terms of suppliers. That's been very clear. We should involve high-risk groups, civil society, to reach some of these populations. And that's one of the means to actually reach the people where we can start micro-elimination work. And some of the work that has been demonstrated today could actually lead on to micro-elimination replicable models. Last, COVID-19, again, we talk about testing and PCR facilities. COVID-19 would have strengthened. Again, I would like to reemphasize this. We have to plan from now. We can start a mapping of where all true NATs are being bought, where all gene experts are being bought, where all PCR molecular platforms are being installed for COVID-19. Post-COVID, these are not going to be used. This could be used for hepatitis B, DNA, RNA for hepatitis C, DNA for Hep B, and also for HIV-related viral load stuff. So this could be put into maximum use that could actually help us pace up our work of diagnosis and putting people on treatment or linking them to treatment. At the end, WHO always is available. I think we would need to chalk out what we need at our own level as to what we specifically need from WHO, both at the country office and also at the CRO level and at headquarters. And we have to go with specific ask, and I'm sure WHO colleagues would be happy to help in that process. So thank you all very much. We would continue to engage. We'll bring people together physically once, as soon as the government permits, a physical meeting of at least 25 to 30 people. Once we have that, we would continue to have this conversation and make sure that some of the barriers that we have pointed out today are addressed. I would like to thank Dr. Tawisak, Dr. Montini, Dr. Satawad, Dr. Nicholas, Dr. Pisit, Dr. Nitya, Kunjoki, and also Dr. Rewari for joining this and giving your insights and sharing your valuable experiences for the benefit of all of us. We will continue to have questions and we will continue to have conversations that will take the country forward. At the end, may I invite Professor Tawisak for closing remark.
Thank you, President. I think I have no closing remark to mention, because you have done such a good thing. So I think everyone will agree with me that we have such a fruitful discussion today with the same common goal that how can we accelerate the treatment and how can we remove the barriers of a treatment in order to become the country champion for the treatment of chronic hepatitis C in Thailand. So I would like to thank all speakers and all parties, and this is quite fantastic collaboration. This is the beginning of collaborations among us, and then I hope that we will continue this collaboration and make this this hope success within the timelines of WHO by 2030. So again, thank you all speakers, all audience that stay with us until the end of the meeting. Thank you everyone. See you soon. Bye bye.
Thank you.
สวัสดีค่ะอาจารย์ทวีศักดิ์สวัสดีค่ะสวัสดีค่ะเจ้ากี้สวัสดีค่ะทีนี้สวัสดีค่ะคิดเต้น